group is the drug-eluting degradable polymer stent, and this is our second value proposition.
I'm Kirsten.
I'm Sunny.
I'm Roger.
And I'm Leah. So did you know that as a woman, I have a 1 in 455 chance of developing esophageal cancer in my lifetime? The chance only increases for men. It goes up to 1 out of 132. So current treatments for esophageal cancer are surgery, radiation, chemo, laser therapy, all very physically draining treatments, and they always take, or usually take, a lot of time. So our target audience right now for our product is hospitals that treat patients with esophageal cancers and obstructions. Our ideal product to treat esophageal cancer is a stent, but the problem right now is that on the market, stents are mainly focused on cardiovascular applications, and most are non-degradable. Out of the stents that are on the market, there's uncoated stents and drug-eluting stents. Uncoated often lead to stent restenosis, so the re-narrowing of the previously blocked artery, and drug-eluting stents often lead to thrombosis, which is complete stent occlusion.
So the way that we're going to solve this issue is by proposing a PLLA stent with a polyurethane coating loaded with an anti-cancer drug called paclitaxel, or PTX. The reason why we chose PLLA is because it's degradable, meaning that the patient wouldn't need a revision surgery to take it out, and it's also self-expanding once it hits body temperature. Polyurethane was chosen because it's great biocompatibility and excellent drug loading capability, and also it's very abrasion resistant. PTX was chosen in the quantity of 10% weight per volume, administered only for 6 weeks, because PTX showed negligible immune and inflammatory responses in animal studies for esophageal stents, and it also has anti-proliferative properties. The polyurethane in PTX will degrade after 6 weeks, which will leave the PLLA stent to provide for structural support, but it will also allow for the healthy tissue to not be in contact with the toxic PTX. So our methodology will be that first the PLLA stent will be prepared in a zigzag fashion. The polyurethane solution and the paclitaxel solution will be electrosprayed onto the stent. Then the stent will be delivered via a balloon catheter and then expand once it hits body temperature, and then the stent will degrade with time.
So some of the benefits of our solution are that it decreases the need for the standard cancer treatments like chemo, radiation, and surgery, which also decreases the patient's stay in the hospital and the associated costs, and improves their quality of life. The solution also allows for better localized drug delivery. Some costs, however, are the FDA approval process might be long and get expensive due to the novelty of the solution. There's costs associated with animal and clinical trials, as well as the testing of the device, biocompatibility tests, and functional tests, which need their own apparatus.
And some of the competition that we looked into include having surgical removal of part of your esophagus and having to be fed by a feeding tube, or having some sort of bypass surgery. There's a lot of endoscopic therapy methods, which include having a stent being implemented into your body. Here are some companies that produce some stents, and there's also cryotherapy options where basically you could go in with an endoscopic therapy and freeze off part of the obstruction. There's also many different chemotherapies, radiation therapies, immunotherapies, and targeted therapies. And our solution is preferable because it's a stent that won't have any corrosive properties, because it's going to be polymer based rather than metallic, and it'll be degradable within 2 to 3 years, as Sunny said, and it will be able to release its drug locally to the esophageal stricture or tumor, and it will also be able to clear any blockages that are in the way. Do we have any questions or comments?